Oh, hey, Chris.
Hey Chuck, you sound down.
Oh no. Oh no. I'm just saving my energy. It's gonna be a high energy show.
Are you pacing yourself already?
That's what happens when you get older. You gotta pace yourself always.
It's funny, I got a lot of sleep last night, but I feel so tired right now. I even had a little caffeine boost at 5 p.m. and I still feel tired. And I realized it's because I got the booster yesterday.
Ah, yep.
At least that's what I'm telling myself.
You could have reached that critical age and maybe all downhill from here. Maybe from one day to the next, you're not gonna be the same.
Oh, I don't want to be middle-aged Chuck, not yet.
Thank you
So
for
I'm excited. I'm excited. We have a recurring guest episode, and we've got Steve Lanier and Jeff Stepan joining us, our former fellows and currently both in practice in Chicago. So let's start with Steve. Remind everybody who you are, and then we'll get to Jeff.
Yeah, so I am I'm practicing here in Chicago at NorthShore University Health System in a sort of private-demic, big hospital system type setting. Alum of the WashU program from 2 years ago, and then did my residency in plastic surgery at Northwestern here in Chicago. So happy to be up here at WashU North with Jeff.
all right,
And
Jeff.
Jeff,
Yes, I am a hand surgeon at the University of Chicago, obviously in academic practice. And I am, unlike Steve, orthopedic trained and did my residency training at the Hospital for Special Surgery. So on the south side now.
just like the HSS practice, I'm sure.
Exactly. Very similar, in fact. Sarcasm
So
there.
I wanted everybody's opinion because one of the things that we talked about before was doing cases that you haven't done before. And for me, I did a new case recently, and I had a 20-year-old young man with some anxiety issues, and he had a P1 fracture that was apex volar displaced, pretty substantial, and there was a little rotational deformity, and it was a transverse extraarticular fracture at the base of the proximal phalanx.
Hey, Chris.
I get the sense that there's no way this.
You are totally freezing up on us.
Oh, it's so weird. I'm like closest to the. Okay. Do you want to present a case then, Chuck, while I figure out my internet thing?
Um, yeah, I can.
Or I can quickly disconnect and reconnect.
Do that. Disconnect and reconnect because we want to hear this P1 case. Oh, you froze again. Damn, brand new house has crappy internet.
You know what
Go back
happened?
to
You
the
know what
basement.
happened is that the fucking pool guys, they cut my AT&T fiber when they were putting in the fence.
No.
And it was like egregious. Like it wasn't even close. Like it had not been, it was barely, it had just been laid. It had not been buried yet. And they just like cut it in half like they were pissed at me.
Oh.
And I came home and I was like, I have no internet. I'm like, I'm on call. I'm like, this kind of sucks. So anyway, they fixed it, but I swear it's slower since they fixed it. So I'm gonna call AT&T this weekend.
All right.
Anyway, yeah, you can put that in.
All right. Why don't you? I don't know where to take it. Maybe just start the
Yeah,
top.
I'll just start with you. So yeah, one of the things that we talked about before was doing cases that we hadn't seen before. And this came up for me recently. I had a young patient in his 20s that had some anxiety issues, but unfortunately had a base of P1 extraarticular, relatively transverse fracture that was apex volar, and there was no way those flexor tendons were going to glide past that. I also got the sense that there was no way this young man was going to tolerate pins. So what are your ways around that? I mean, Steve, would you consider, if you didn't want to pin this and you decided this needed surgery, would you put a plate on this?
It depends on how proximal. Like one thing I've done a few times is headless compression screws for this for similar reasons, people who I don't think are going to do well with pins or multiple P1 fractures with really swollen hands and I want to move them really quickly. I don't really have enough experience with it yet to really weigh in on my thoughts, but if there's enough substance at the base of P1, I think that's a good option.
Did you see that a lot in your training, or did you start that when you went into practice?
I did not. I did not do it in training, but it's a technique that people have talked about and I'm familiar with. One of my partners does it. So, I watched him do one, kind of got some tips from him, and then waited for what I thought was, a good patient, to do that for.
Talk to us about your technique. If you are, I believe you're talking about maybe a proximal 1/3 or even more proximal fracture of the proximal phalanx. Where do you insert the screw, and how do you think about it?
Right. So if I guess there's two ways to do it. I've done both. You can do either two micro headless compression screws as an A-frame. Those you can insert percutaneously, similar to how you would a K-wire. So you get your guide wire in place, make a little mini incision, and then drill and insert the screw that way. Or just, I've done a arthrotomy of the MP joint. Basically volar directed pressure on the base of P1, slide the guide wire in, and then put a headless compression screw over that. And I have talked to patients, about the fact that we don't have long-term data on whether this causes any arthrosis of the MP joint, and that it will cause some swelling, but we're weighing that against the benefits of moving early and, more rigid fixation. So.
Chuck, how do you approach this kind of case? And then we'll get to Jeff's thoughts.
So I have, over the last probably 2 years, maybe when a more skilled set of fellows came in, I may have changed my technique. No, I think over the last 2 years, I have started doing more headless compression screws for metacarpals, for sure. I did one yesterday, and it's such a pleasure, and I feel fine given that pretty dorsal insertion point on the metacarpal head for the retrograde headless compression screws. I have not yet used the same technique for the proximal phalanx. It feels like the screw size to the articular surface ratio is very different. I respect you guys, obviously, but I also respect Kathleen McKeon, who's down at Andrews Sports Medicine in Birmingham, and she's an advocate of that technique as well. So I think ultimately, eventually I'm gonna have to try it. Currently, if I don't use pins for a transverse fracture, I probably would put a plate on and be happy with it. I've been happy with that for years. Nothing wrong with it at all. Get the patient moving early, and not a negative in any way, although I am intrigued. I'll turn it over to Jeff.
Yeah, I also have not done a headless compression screw for a proximal phalanx fracture. Although funny story is that we have a fellow at the University of Chicago, and they go up to NorthShore and occasionally operate with Dr. Lanier. And she actually said how smoothly the case that you did with that dorsal headless compression screw went. So anyways, seems like it went well. I'm sure you liked it, but I would probably try that if it came across. I have not done one yet, but yeah, I've been plating my proximal phalanx fractures, but they have not been transverse and clean like that. So
This was the right fracture, and I went for it. I did the Lanier technique, and I'll say, if I get another one of those that lines up beautifully and is transverse, and there's enough base of P1 to sink the headless compression screw with enough purchase, I'm gonna go for it again. I thought it was great. We'll see how they do, obviously, in terms of therapy, but very, very happy with it.
So again, just clarify for me, and maybe I'm only slow one, but maybe another listener too is also slow. Exactly where did you insert the screw? So you described it as mid shaft, maybe it was a little more proximal, but it used a micro headless compression screw. And where exactly did you insert it?
So center on the AP view or PA view, and then on the lateral view, it's kind of at the dorsal third, middle third junction. And in order to do that, you're hyperflexing the MP joint, and like Steve described, taking your thumb and kind of bringing the proximal phalanx up and dorsally translated. I did it with, I put the guide wire in percutaneously and then made a stab incision around it, and then drilled while, retracting away, kind of a split in the EDC, and then drilled while, protecting the EDC. And depending on the implant you use, you may run into length issues with the screw. I didn't use the screw specifically designed for the proximal phalanx. The micro skewer I used, the longest one is a 30. Lo and behold, 30 was perfect.
And did you get compressive bite, or is this more of an internal strut?
Compressive bite. So I actually was a little nervous, so I went ahead and did one collateral recess antegrade pin like I normally would, and then was kind of looking at the rotation and got the reduction as perfect as I could before putting the guide wire in, just because I didn't want it to only be an internal strut, for my first one at least.
Nice. I have to say, when I do that first, I'm not going to do it the way you did it. I think that was bold. I am going to open it and not percutaneously do that, but kudos for pulling it off.
Well, I read somewhere on the Twitter sphere, I think it was from Jeff's senior partner, Megan Conti-Mika, who described it being harder if you open it versus perking it and then opening it. And a number of people endorsed that comment. So I figured that was the way to go. And no, I do not learn my hand surgery on Twitter, but it was useful.
Nice. All right.
So let's talk about, you guys had this great symposium. So not just an ICL, a symposium at the ASSH meeting. Was it called Free Solo?
Free Solo.
Take us
That's
through
right.
what was that and how did it go?
Well, first, set the scene for us. When did it happen? Was it Saturday morning at 6:30 a.m.? Or what was the time? What was the audience like? What was the
Sure.
room feel?
Yeah, absolutely. I mean, there was palpable thrill in the room at Saturday morning at 9:30 a.m. Actually, not 6 a.m., where I thought we would probably be. But I think it went really well. I mean, there were a good amount of people in the audience, obviously mostly trainees, obviously, as the title of our symposium went. I don't know, Steve, what did you think about the number of people in the room?
Yeah, I was, it wasn't full, but more than I anticipated. Like Jeff said, some trainees, some people who have mentored one of us and wanted to, see us fumble around up there. But it was fun. I think it was well received. We got good feedback. Jeff did a nice job leading us. Even had snacks for the panelists in case we were hungry, which we really appreciated. So.
Yeah, it was great. I think we pulled it off. We executed what we wanted to execute. Whether or not that actually provided useful information to anyone, that's a different story. So.
So some of the listeners will now hopefully go catch this on the Hand Society website. For those who are not ASSH members or don't have access for whatever reason, can you give us a high-level summary points, takeaway points for what you guys demonstrated during the symposium?
Sure, absolutely. Steve, do you want to talk about what you talked about?
Yeah, so we each kind of had a different focus. Mine was on practice building, and kind of the main point was that you have to take the initiative. No one is going to do it for you. And a lot of the things that, I think a lot of people know, being available, being nice to everyone, kind of finding out what the referral networks are in your system and kind of how you fit into that, and just basic things like if someone calls into the phone tree, how do they end up in your clinic, and sort of making sure that you are at the end of that chute that's funneling patients, towards hand surgeons. So that was my focus.
Yeah, and we had a few other panelists, and they spoke about setting up your clinic, setting up your operating room, time. I spoke a little bit about time management and research, and so those were the main highlights there. And it really was geared towards the fellow or the senior resident really about to start practice, and what are the little nitty-gritty things that you need to start in the operating room. You have to be prepared for every single case. If you're at an ambulatory center and they don't have something and you run into a bind, well, then you're not at a large academic center where everything's on the shelf anymore. So little things like that, I think we really focused on, and things that you never thought about while you were actually in training.
Now, Jeff, that's really impressive that you brought snacks. I've been on several panels with Chuck, and he has never brought snacks. So you're already surpassing the expectations of your mentor. Let's just put it that way. So, what do you think that you've learned in the last few months or 6 months? The last time we talked was in I think July. What did you learn that you didn't know back in July in terms of running a practice? Start with Jeff, I guess.
Yeah, back in July, so what is that, about five months ago or so now, 4 months. The clinic is starting to fill up and be a lot more consistently full now than it was in the past. I'm no longer, worrying about the clinics next week that aren't quite full. They're gonna fill up, and I'm just kind of go with it. And a lot of people are coming back. It's been a year into practice now. We've done all the non-operative management, and patients are eventually, they get the year out of their trigger finger or whatever injection, and they're now starting to come back. And I'm having those second conversations with the patients, and so patients actually are coming back, and I guess we're hopefully happy with the care at first. But it's nice to see the cycle, which you hear about, but until you're a part of it, it can be a little nerve-wracking.
Totally, I would agree with that. Starting to see some of the people with thumb CMC arthritis I've injected, over the past year come back and looking for other options. Finally have a four-corner fusion booked after a year in practice. So some of the more, elective, so to speak, sort of cases are starting to come, as opposed to, mostly trauma for me, which is nice.
I would also add that, some of the early work trying to get my name out there within the university to, say that I'm interested in nerve surgery is starting to pay off. And a lot of people are funneling some of those referrals to me that they don't want to deal with. And I'm obviously happy to handle them. And so that's actually been really good, and that's been picking up. So.
Yeah, I've noticed, so I think I mentioned before that I've given some talks to OTs in the city, and Chris is going to love this, but I gave a talk on ulnar-sided wrist pain, and I had a patient come in with a TFCC injury who was referred by an OT who I don't know, who said that she heard me give a talk on this topic. So it's like the first direct evidence I have that has in some way contributed to building the practice. So.
Wait, so the plastic surgery resident that came in saying, I'm really interested in peripheral nerve surgery is now giving talks on sports and is now doing the sports. Chuck, you win. I give up. I give up.
Well, I'm proud of one of you. Congratulations, Steve. Excellent work. All right, let me just play a little game. So CMC arthritis. Steve, you're taking the patient to surgery. What operation are you doing?
Internal brace, or trapeziectomy with internal brace to suspend the thumb metacarpal.
Jeff?
Wow, some training paid off there. I've done two now in practice, and I actually did a case that I hadn't done before in training that made sense to me, and that is the APL to SCR sling with sutures, because I think it accomplishes the same thing without implant cost. And I think you can get them moving just as soon. So we'll see.
So that brings an interesting point, because we don't do that case here. And how did you prepare for that case? Was it just, I'm confident in my skills, I'll read up on the technique? And how did you kind of go about executing that in the OR?
Yeah, absolutely. I mean, I think the approach to the case is very similar for all. Obviously, trapeziectomy comes first. And so that's no different than anything we've done before. And, I spoke with, multiple different people about how they do this specific technique. And again, Dr. Kantamika, who you looked up in the Twitter sphere, told me how she does it. And I talked to a few others who really enjoyed that technique. And, I think I went for it, and it's not complicated. You're just passing suture between two tendons. And I think the complicated thing may be tensioning the length, but kind of, I guess, just read up on it and did it because I didn't think there was too much more involved than that. I don't think it was as complex as maybe some nerve transfers that maybe get into the cadaver lab first.
So, Chris and I are proud of the listenership. We've seen our listenership grow, and, most of the points that we make are not all that subtle, and I don't think you have to listen carefully, but I just want to rewind just a little bit. So we asked Steve, how would you treat CMC arthritis? And Steve gave a nice, simple answer and just told us what he did. Jeff gives a different answer and then has to justify it like a true academician. So I love it. And what, you had to tell us, and then why you did it. You're trying to convince Chris and I, and maybe you did. That was pretty convincing, I have to say.
Well, not like the private practice guys up there just throwing in implants left and right.
Shots fired. Well, Chuck, you have to remember.
Sorry,
You have to remember where Jeff trained. He trained at HSS and WashU, where all we do is talk about stuff. So.
I know.
So Jeff, Steve, you brought up an interesting point, and both of you did actually, that you don't do a lot of the kind of elective bread and butter hand surgery until you're further on in practice. I mean, Chuck, did you walk into a mature practice where you were doing LRTIs right away? I mean, when I started, I didn't do an LRTI during all of board collection, or a thumb CMC surgery, I guess I should say. And I think it was almost another 6 months after I finished board collection before I did one.
Yeah, it's a great point, and certainly I think Jeff and Steve's experience mirrored my own many years ago, where patients had to dial the telephone to get into our office with the little rotary dial. It gets to the importance of taking call. It does, as you guys both have said, get to the importance of getting your name out there. And a busy practice where some of your partners have mature practices automatically funnels trauma to you. And it's an unbelievable feeling when you start to see those patients back, which means, you had a good conversation with them and the elective stuff comes in. It took me, and I am not exaggerating, maybe I'm a little more of a stressor. It probably took me 10 years to stop worrying about the ebbs and flows of practice, where, one clinic I'd be full, the next clinic not so full, 1 week a busy OR, the next week not. I stressed about that. I looked for problems, and for years, I don't do that anymore, but my goodness, I don't know if you guys are stressing about every little peak and valley.
It's interesting that you say that, because, I took a little time off in September for my wedding, and then we went away for 10 days. So I was basically gone weeks, and, things had ramped up to a pretty steady level. And when I got back, my clinic was empty. And I was like, well, it's been a good run. I guess I'm done, but because, I didn't see patients for a while, so I didn't have anyone really returning as frequently. And then I wasn't, on call, so I didn't have cases lined up. And it took a few weeks after getting back to start to get busy again. And so kind of experiencing that dip, like you said, is anxiety provoking to some extent. But.
And are you guys, either of you, using the internet to try to build your practice, whether that be a blog or making sure your website is robust, or even Twitter? Or at this point, is it more face-to-face and just doing the right things on a day-to-day basis?
I guess I can start. And for me, I have not had the bandwidth to go on social media and put my name out there. We have our University of Chicago website that I have, but I don't have a separate website or separate blog. I do think that might be the next step in terms of, getting out there a little bit more, especially with some of my interests. But I think more face-to-face and getting the word out there to individual practitioners has been good so far, but we'll see what the next steps will be.
Yeah, similar for me. I'm not a big social media guy to begin with. I don't use it a lot in my personal life, and so I'm not terribly adept at it. And I've just been focusing on trying to do a good job with surgery. Trying to network with people within the health system. And if I get to a point where I have the bandwidth, like Jeff says, and I feel like that it might be helpful both for patients in terms of building a website where people can refer to, or building the practice, then maybe something I would consider, but not yet.
So Steve, you mentioned recently that you're going to be sitting for your oral boards, and maybe next week. What's that process like? It's a little different for orthopedics versus plastics, but I'm pretty sure the stakes are just as high for everybody, and it's as stress-inducing as anything else.
Yeah, definitely. So, it's a two-part board certification process in plastic surgery. There's a written board, which I actually took during fellowship and passed. And then your first 9 months in practice, you collect all of your cases. It's a little different from orthopedics, where you have a little window to get started and then start collecting. So I basically collected data on every case, submitted it to the American Board of Plastic Surgeons, and then they selected 8 cases for me to compile books on with all of the records involved in those cases, pre-op pictures, pre-op images, post-op images, pictures. And then they're basically going to spend a day examining me on those cases, asking me, why I did what I did, what I would do differently, those sorts of things. And then there's a second day where I have unknown cases, which is going to be 7 cases that could be anything within plastic surgery, which is a very broad field. So it could be cleft lip and palate, someone's ear is missing, abdominal wall reconstruction. There's always one hand case in there, one token hand case. So I'm prepared for that one, but most of my time has been spent over the last month just refreshing on all of the things that I don't do regularly and haven't thought about, for a few years now.
Wow, that is intense. I mean, Jeff's got it way easier. All right, Jeff, tell the listeners who may not be familiar with the orthopedic board process how it is working or will work for you.
Absolutely. So similar. There's two parts to it, and the written part is before fellowship for orthopedists. And so part 2 is we start case collection similar to Steve, but we start, after about 6 months into practice, and we spend 6 months collecting cases, very similar, and submitting them. And so I just submitted my cases a few days ago. And so that was good to have that, off my back and no longer, worrying maybe about every word and every note quite as much, which is nice. It takes a little bit of pressure off and a lot of time entering cases into a website. So we will see how that goes. I know that the orthopedic oral boards were just a few weeks ago here, and I saw some old friends that took it, and no one ever feels good after that.
So it's in person.
For some people.
Okay. Ours are via Zoom. It's the second. So they started last year, kind of when the pandemic was going stronger, started doing it via Zoom. And then the decision was made earlier this year that they would continue that at least for this year. Previously people go to Arizona and stay at a hotel, and everyone's there at the same time. But
of course it's Arizona. Of course it's Arizona. I mean, you're a plastic surgeon. I'm surprised it's not Hawaii or something.
So how did each of you set up your practices to optimize kind of data collection for board stuff? I'm pretty sure that you had some workflows in place to make things easier for when you had to enter data into the computer, as Jeff was saying. Start with Steve, maybe.
Yeah, for sure. I mean, I think, for me, there's a book that details everything that is going to have to be submitted. So I read that book twice, made sure I knew everything I had to collect, and then I kept a spreadsheet with that data. In plastic surgery boards, they scrutinize your billing as well. So I reached out to the billers and coders and let them know that, I usually code for myself in clinic, and then I put suggested codes in my op note. And so I reached out and let them know if there are any changes to this, please let me know so that I'm aware of it. And then, they also require photographic documentation for every patient, both pre and 3 months post-op, which doesn't make a lot of sense for a carpal tunnel, but at the same time, I had to make sure these patients are coming back on that time scale so that I can get appropriate photos if those cases were selected. So just kind of knowing what is expected and just kind of staying organized was important, I think.
Yeah, I think for me, a little bit less stressful with, not the need for photos, but I guess we have our radiographs. In terms of, submitting cases and make it a little bit more streamlined for me, it's, you submit your case when you book it. And then on the back end, you have to put in complications, ICD-10 codes, ICD-9 and 10 codes, and CPT codes. So I incorporated my, administrative assistant into actually entering just the basic data. And then after every case, I would go in, so I kept on top of it and enter what I thought were the appropriate CPT codes and the appropriate diagnoses codes into it. And then at the very end, I just went back and went through all of them to make sure we had the good follow-up there.
Chuck is very good at this data entry process. And Chuck, do you still have now it's probably mythological status Goldfarb spreadsheet of cases from the last 30 years?
I do. I do. I keep track of my cases to this day on a very secure platform behind, all kind of locks and keys. And yeah, it's incredible. I can tell you, if you said how many proximal carpectomies have you done, I can tell you in 2 minutes. It's really remarkable for research. And it's also one of those things that, it's just what I do. And it's just part of the process. Before every case, I come in, well, I design my own schedule. So I always have flip rooms. So I design my flip rooms myself, which I think is helpful. I review the cases the morning of, I go through the electronic medical record. Obviously, I do the surgeries and then I record the surgeries. And it really does help imprint things for me, is one reason I like it, that multi-step process. But it does take time, although not all that much. Chris, what do you do?
So I started a similar process, but I do not have the discipline that you do. So when my nurse hands me the post-op packet for the patients, she has my booking sheet. Before Epic, before we had access to Epic on our phones, I would have her put the last the last office note in there, and then the consent form, if just in case they lose a consent. So then I'll have that in a plastic sleeve, and then I'll take that plastic sleeve and then put it in my office, where my secretary will put it into a spreadsheet that I started in the wanting to be like Chuck and then realizing I couldn't do it. So at the very least, I have a spreadsheet with all of my cases, with the exception of the occasional ortho trauma case that doesn't get put in there. But it is incredibly useful. I've also found it very useful. Somebody asked me how many common perineal nerve releases I've done, and all of my cases are in Outlook as well, secure of course, but they're in Outlook. So I just quickly type in CPN, and then for the last 4 years, the number of cases just pops up, which is very useful when somebody's asking you as a younger surgeon, how many of these have you done? You can tell them pretty quickly.
And you double that number like most surgeons do, or do you give them the actual number?
Most surgeons actually triple that, and I'm feeling that as we try to enroll in our prospective brachial plexus cohort study, in which some centers just don't do. All centers do not do as much as they say they do. So maybe let's finish out with a more fun topic. So Jeff, we'll start with you, and then go to Steve. So how have you found a way to keep your sanity through all of this? You're obviously very busy, and I know your wife is a surgeon as well. And then, Steve, I know your wife is in medicine as well. So how do you guys, take care of yourselves and take care of your family?
Yeah, that's a good question. Sometimes I don't know the answer to that, how we're surviving, but right now we just have a dog, no kids, so it makes things a little bit easier for us. And we just communicate, share each other's schedules, and making sure that one of us is home when we need to be home, and split up all the household duties, which is difficult because we just moved, similar to you. But to keep our sanity, we block off every Monday night. We play co-ed soccer together. So that's a very fun activity. And then I have soccer maybe one other night a week. And honestly, that and some exercise. My wife just bought the Peloton tread, so she's looking forward to the cold winter here, running in our basement.
Hey, tell me about the move. So you were in an apartment in the city, and you are now, it sounds like, in a home in a suburb?
Kind of, yeah. We were in Streeterville, in an apartment, and we are now in Lincoln Park, which is still technically in the city, just a different neighborhood, and it's in condominium, but it has its own private entrance, and so it's definitely a step up. No longer the views of the lake in downtown, but definitely more space, which is what we wanted. So
awesome. All right, Steve, catch us up. How do you maintain your sanity?
Yeah, I mean, it's been a crazy year, not just with work, but, like Jeff, we moved, we had a wedding, which like towards the end just sucks all of your time, trying to plan all those last few details. So I'm glad that's over. But then I went immediately into like into preparing for boards, sort of full steam. So I'm looking forward to next year when I can settle into a routine. But one of the things that we did, within the last years, we joined a nice health club that's close to us. I've been leaning on Jeff and Caitlin pretty hard to also join the said health club. But it's just a really nice place to be. I mean, it motivates me to go work out because it's a nice place to be, and nice sauna, places you can shower before work, places you can get coffee. It's just, it feels like I'm pampering myself a little bit. So it kind of gives me that extra motivation that I need to actually maintain consistency with my fitness. So.
Good for you, man. I mean, I think that's great. Treat yourself. That is good.
You deserve it.
You do.
Jeff will be in there within a few weeks.
Okay.
So Jeff, just to give me a baseline, so I know. So is this, how much fancier than Equinox is the gym that Dr. Lanier is speaking of?
I think it's about the same, except a little bit bigger.
Oh, okay.
Yeah.
All
Does
right.
Equinox have a golf simulator, Jeff? I wasn't clear on that.
It sounds like our recurring guests are doing great.
It does. It does. It's so nice to catch up.
So we have our fellowship applications coming due. Maybe by the time this airs, it'll be within a couple of days. And Dr. Lanier, I'll be knocking on your door to help us potentially interview applicants. The alumni room was a huge hit last year. So thank you so much for doing that. And
Awesome. Yeah,
Jeff,
it was
Jeff, you obviously have a conflict of interest, so you cannot interview our applicants.
You don't want me stealing them up to Chicago.
But yeah, so thank you for joining us. Hopefully we'll have you guys on again in a few months and you can update us on what's going on in your lives.
Awesome. Thank you. This was fun.
Yeah, thanks. Always great to see all of you.
Thank you so much. I'm glad everyone's doing well. And Steve, congrats again on the wedding. And Jeff, congrats on the Peloton tread and the new condo.
Totally the same. All those things. Yeah.
Similar.
All right. Y'all take care.
Bye.
I'm trying to stop.